So if we can have the panelists come up, Xianjin Zhou, Xianjin has a history in schizophrenia genetics research, and Jeffrey Max. And Jeffrey, I was very interested in having here because of his work in child psychiatry clinically, as well as his work with another devastating problem that can occur in childhood, which is childhood brain trauma. And most importantly of all, and serving as the chair and member of the committee, is someone we all know well, who helped introduce, this is Symmetry, helped introduce the sessions to begin with yesterday. And Sam Barondes, a founding member of this department, a superb scientist, and a past chair of the University of California, San Francisco Department of Psychiatry. Come on up, Sam.
So, I mean, this is a wow. This symposium was really spectacular. Wow. I was right. And, you know, to pack all this into like the time we had, and it was pretty clear to me anyway. I don't know where to start, but I'm going to try to. Okay. My intention, which and I'm glad you introduced the panelists who we'll get to shortly. Okay, but I want to talk for a couple of minutes first. So my intention was, and I'm going to follow it just very briefly, to say that I became interested in psychiatric genetics while I was still a faculty member here at UCSD. And I'm just going to tell you one brief story about that, which got me interested and led me to many other things. So around 1978, which is 41 years ago, I got a call from a psychoanalyst in Los Angeles who had a wife who died of Huntington's disease. His name was Milton Wexler. And he was thinking of partnering with another family to set up a foundation to help do something about Huntington's disease. The other family was named Guthrie. Marjorie Guthrie was the person, the bereaved spouse. Her husband was Woody Guthrie, very famous folk singer. And in both cases, there were children. So Marjorie had a son, a beloved son, Arlo, who you may know, who's a singer. And Marjorie was, and because both of them had been told that this was a genetic disease, that it was known then, very clear, this was Mendelian stuff, that those children each had a 50-50 chance of getting this disease, and it was a horrible disease, and they had watched their spouses wither away and die of this horrible disease. So what should they do? So I knew Milton, and they were thinking about stuff, so I met them at Marina Del Rey. There were a few other people there. We want to set up a foundation. Milton was also very connected with Hollywood. Milton was a Hollywood psychoanalyst, and one of his famous patients, and this is public, was Jennifer Jones, who was married to Norton Simon, who was a billionaire then, when a billionaire was a billionaire, none of these techie billionaires. This was a real billionaire. So there were a lot of potential means, and they were connected to the whole Hollywood community. And okay, so they wanted to set up something that was going to be funded. And there were 2 points of view at the time. Marjorie said, look, Arlo might get this. We got to find a treatment for it. And, you know about drugs for mental illness. Let's find a treatment. And Milton was agnostic. He was less convinced that drugs were going to work because he was a psychoanalyst, He's right. I mean, it's a reasonable position. He was psychoanalyst, and he wasn't saying psychoanalysis was going to work either, which I was relieved to find out. Okay, but and I said, I know a little bit about molecular. I don't know much about human genetics, but it seems to me that the drugs are, forget it. Our drugs are not very good. To try to figure out a drug for this disorder, it's just genetics, it's pretty, how the hell are you going to do anything with genetics either? But at least I understand what you could do, and there could be some good science here. And I'm going to go talk around to some people and find out if maybe that's a possibility. And I did. And I learned about, there were RFLPs were just beginning to be thought of, the Botstein paper about RFLPs, a marker for, the genome was this vast unknown wilderness. Anyway, to make a long story short, they decided to go into genetics because some excellent people that came to help them said, yeah, we can do this. And in a short period of time, they found the locus for the Huntington's disease gene, which offered an opportunity for prenatal diagnosis. But they decided they weren't going to have kids, whatever. I don't want to go into it anymore. But be that as it may, that is the place that I come from when, and I started dreaming, well, yeah, maybe there's maybe bipolar disorder, which John Kelso talked about. We thought maybe that was going to be a Mendelian disease, and you remember David Hausman and the Amish studies, and there was a paper in Nature, which I actually read and reviewed, which alleged that maybe bipolar disorder was Mendelian, and these were the same people who work in Gazella, who found the Huntington's gene, was part of that group, and it was looking like, yeah, psychiatry, all of a sudden, okay, but hard. And then it was hard. And John gave a beautiful review of the iterative progress from very hard to getting a little better to getting a little better. And today we hear this set of talks, and they blow my mind. They really are. They're absolutely state of the art. And we can start really thinking. It's still really super hard. Certainly diagnostics. Clearly, but also, every one of the talks had just spectacular stuff in mind. So that's what I had to say. And I would say a lot more, but I also want to give an opportunity for our panel to speak, and I also want to give an opportunity for the audience to maybe ask some questions to the four brilliant speakers, because they were so time constrained, and there's so much gold in what they had to say. So that's my panel.
Well, I would agree with everything you said, but I'm going to summarize it a bit shorter. What Mark Schacher doesn't know is that I am a part-time stand-up comedian, but I'm not going to do anything about that today. Yes. In fact, I'm going to be a sit-down comedian today, and that's where I'm staying. So just briefly, for John Kelso, he talked a lot about GWAS, but I think this was a GWIZ talk, actually. When it comes to Abraham Palmer, as a child psychiatrist and interested in developmental theories, I think he explained it all. He's from Eugene, Oregon, and this is your gene study origin, which he taught us about. When it comes to Jonathan Sebat, he was trying to differentiate himself from Abraham Palmer, and indeed, he gave us a hair-raising talk. And finally, with Lilia, a couple of things to say. It was a very cultured talk, and this is a new version of cultural psychiatry that's very impressive and something I didn't anticipate. So enough of that. I haven't done any genetics work. I wish that I had. My work is in traumatic brain injury, and given this and some review of some of the genetics that are recently been done in pediatric traumatic brain injury, is encouraging me to actually connect with some of these people. And I think really part of the strength of our department over the 50 years is this enriched environment that we have, and it's gotten so big that we don't always communicate because we're further apart. Our nodes are further apart. But so this is, I'd say, looking at this conference, it's not just looking back, but hopefully it will be a promoter area to look forward. For the child brain injury stuff, I'll just mention a couple of things that have been done, which are probably, as I listen to these talks, are quite naive. It's sort of a shotgun approach. But the general approach, I won't go into detail, is looking at genes which are thought to be behaviorally related, like the dopamine.
I'm
sorry.
Focus.
What's done in pediatric head injury is looking at genes that have something to do with behavior, like the dopamine transporter or dopamine-related genes, and then looking at data where psychosocial data, family data, environmental stressors, that kind of thing, are put together with the genes and looking at clinical outcome, like with executive function and behavioral outcome, and not really yet psychiatric disorders, and looking at differential influences on that. And so that's an area where I could see myself going, using some of the large, well, it wouldn't be large compared to the 150,000 that you're talking about, but in the clinical studies, they're getting some interesting results from populations of 200 or 300. And that's I'm going to be looking at that to pick your brains to see whether it's feasible with clinical populations that I deal with. Sam had asked me to comment a little bit about expectations that I would have as a clinician in the next 5 to 10 years of using, like this lithium rescue that John spoke about, or some of the other rescue or changes to normalize function. It's very hard for me to imagine that in the next 5 to 10 years. I would see a longer horizon. I see opportunists, I think. Maybe that's too judgmental here, but many of my patients come to me asking me whether they should get the $500 genetics test to look at which medicine they're likely to respond to. When I've looked at the printouts, it doesn't tell me which medicine they're likely to respond to. It just tells me whether they're fast metabolizers or slow metabolized for particular enzymes. And so it tells me which medicines that I might start at a low dose versus which medicines I might expect to go to a very high dose and not give up because of lack of effect. So that I can see that's already happening. But I think we're going to have to wait a longer time unless there's some dramatic breakthrough, which I certainly don't see at this point in the next 5 to 10 years.
Okay. Well, the 4 speakers just gave us wonderful presentations. I think some of them are really pioneering work and covering from polygenic risk factors and a rare genetic mutation in human and mouse and different psychiatric disorders. I always think psychiatric genetics is particularly important because psychiatric disorders do not have pathology. We really need genetics to tell us where to start the biological basis of psychiatric disorders. So I received the same assignment from Dr. Barondes a few days ago and asked me to talk about what the psychiatric genetics will look like and its impact to clinical psychiatry in 5 to 10 years. I think this is very difficult and biased, and I feel like I have more confidence in predicting stock market than predicting what psychiatric genetics would be in 5 or 10 years. So,
Well, you can do that if you want.
but I will try my best. As I said, it's very biased. It's from my understanding. And I want to discuss 2 points with the audience. One is what the psychiatric genetics has already tell us, what's its potential impact fact to clinical psychiatry. And the second, I want to also discuss about the limitation of the current psychiatric genetics. For the first one, I think it's about people I'm going to talk about focus on schizophrenia because that's the area and I read most. So people in this field probably know about the GWAS studies published in Nature article. I believe this is 2014. 108 loci being identified and achieved genome-wide significance. So one of them, actually, that's quite different from the rest of them. That's the MHC locus on chromosome 6. That locus is several orders of more significance than the rest. What about this locus? This locus is the most important genetic locus for immunology because it's about the T cell development. It's about the antigen and processing and presentation. Now, of course, this locus is the risk locus for many autoimmune disease. Now, I think recently there is emergent field in the psychiatry is the synaptic autoimmunity, and particularly is anti-NMDA receptor autoantibodies first identified in anti-NMDA encephalitis. So this disease actually is very difficult to differentiate from schizophrenia. So they often misdiagnosed as a schizophrenia. So that tells that synaptic autoantibodies and may play an important role, at least in this subpopulation of patients. Later on, people working in psychiatric field look like this is a wonderful concept for them. So they look at how prevalent of this synaptic autoantibodies in the blood of psychiatric patients. I think it's still early, about 10% of their claim. Well, there's some variation. Some people say more, some people say less. But it's pretty significant, not only in patient, but also in control. Now, my question is, whether that the MHC locus that's biggest determinant in the antigen processing and presentation may be involved in the synaptic autoimmunity in psychiatric disorders. Second, I think the point I want to discuss is the limitations of the current psychiatric genetics. We talk about current psychiatric genetics deal with the single copy sequence in the genome, maybe multiple copies of a single copy sequence. But 2/3 of our genomes consist of repetitive sequence. We call them junk DNA. But people more and more realized maybe the dark matter in the genome and involved in the organization of the chromatin, just like dark matter in the universe. So I want to, just give you 2 examples on how this repetitive sequence may be involved in neuroinflammation. So one is the human endogenous retrovirus. That's very much like the HIV virus, and it's just get integrated into our genome million years ago. So that constitutes about 80% of our genome. They are pretty much dead, but not completely. So overactivation of this endogenous retrovirus causes neuroinflammation in multiple sclerosis. The second example is the allele family of this repetitive sequence. An allele family transcript abundant transcript that form a double-strand RNA. These need to be edited by RNA editing. If RNA editing has a mutation, and the patient will have a genetic inflammatory disease with constant inflammation, that only very interestingly affected organ is not just the every organ, it's brain and the skin. So what does that mean? So that I think is our brain may be particularly sensitive to the double-strand RNA-induced neuroinflammation. So we know neuroinflammation play a role in psychiatric disorders. I think this repetitive sequence may have a role in psychiatric disorders. I hope in 5 or 10 years, with the technology advancement, we can look at this dark matter in our genome. Yeah.
Thank you. Okay, I don't know how much more time we have. I'd like to take a lot more time. I'd like to at least ask if there are any questions that anybody wants to answer. To answer. Any specific comments from the speakers or?
Yeah, I'm sorry. I'd like to know a little bit about the father factor in the autistic boys, if you will. Thank you.
Yeah. So we've speculated. So when we first published a paper showing there's a increased contribution from fathers, we speculated that there might be some epigenetics involved, imprinting, or maybe there was some interesting interplay between mom and dad, where mom was contributing one type of risk and dad was contributing another. But I'm actually leaning more towards a different theory now. I strongly suspect that there's a pretty strong ascertainment bias in how we recruit quad families. So when we recruit families at Children's Hospital, the point of contact is usually a neurologist is seeing the family, and then they describe the study to the family member, and then they refer them over to us. That family member, who's the point of contact, is 90% of the time the mother. And the act of simply, so we don't get every single referral. To some extent, there's a self-referral by the mother to our study, dependent on, her availability to have more time, dependent on her interest in the genetic study and her ability to understand the genetic study and the interest in genetics and also probably not believing that vaccines is the cause of her child's autism. Selection bias acting on the mothers when you recruit quad families. And I think that that's actually maybe the driver about why we're seeing a relatively small genetic contribution from moms. That there might be so mothers who were more genetically loaded might be the ones who are not self-referring to our study, that those families might be struggling more. And that's why we're not getting them. And so we're by virtue of losing those families, we're enriching for the families where dad carries the risk. And dad, there's not as much of a selection because mom will drag dad kicking and screaming into the appointment to get his blood sample drawn. The ascertainment does not go the other way around.
Always psychosocial explanations.
Thank you. It was a very interesting panel. And the way that the panels worked out with the lectures was really very rewarding. The only thing that I regret is that we didn't have more time for audience participation. But these 2 days were just fascinating to me. And somebody said we should do this every year. Indeed, it gets us all together, and I've learned some wonderful things. But before we all go home, I would like to turn this over to Igor Grant. This was put together in primarily with Igor and to celebrate our 50 years, and these last 5 years have been dynamite.
Well, thanks very much, Mark. I promise not to take much time here. I'd just like to very much express my both appreciation and awe at this 2 days of science. We have heard, by my count, 27 papers, participations by 7 panels, and involvement of 56 faculty of this department in these 2 days. And I think that is as good as practically any meeting I've gone to, scientific meeting, bar none. So it's really a wonderful celebration of the department and what it's doing, and a tribute to the faculty and the research staff who have performed all of this work. I want to also particularly thank Mark and Pat Judd. Is Pat, did you kick her out or something? Or okay, she got to go home. But Mark Schuckett and Pat Judd spent many hours coordinating these 2 days of science. And I know you've also involved other faculty in the planning. You had mentioned, I think, in particular, Abraham Palmer and Mark Geyer. Thanks to you both as well. And I want to also acknowledge, again, the staff support that we've received from Felicia Roston, Carla Engel, and Sean Rybach, who's sitting there, who's been managing the IT. And this is some of the best IT support I have seen in any meeting. Just about every meeting you go to, somebody says, oops, slides are sideways, something's not happening, the audio doesn't work, whatever. Fabulous. And Sean has promised that very soon he will archive the entire proceedings on the Department of Psychiatry site. So if any of you want to look at yourselves again, or maybe Photoshop some things that you didn't like, you can do so. But seriously, it'll be an archive. So thank you very much. I also want to thank people who have come from abroad, like San Francisco. Sam, thank you so much for being here. Oklahoma, Martin Paulus. Who else is here from strange places? Not anybody right now. But really, thank you so much for joining in this and making it a success. Okay, now you can go home.